All right. Future UK doctors, let's get real for a second.
Okay.
You're staring down the MSRA exam.
Right.
The pressure's on, and suddenly, bam,
Oh, yeah.
a question about myocardial infarction pops up.
Heart attack.
Don't sweat it,
Yeah.
because this deep dive is your secret weapon, okay?
Huh?
We're going beyond just memorizing facts,
Really?
We're diving into MI specifically for you,
Yeah.
someone prepping for that crucial MSRA exam.
Mm-hmm.
We've got your back with the latest guidelines from the NHS and nice insights from the British Heart Foundation,
All right.
and even some MSRA-specific advice from our friends at pathophysiology.com.
That's right. We're not just aiming for a passing grade here.
Right.
We're talking about equipping you with the knowledge to actually understand and apply these concepts in your future practice.
Because, let's face it, myocardial infarction is a leading cause of death in the UK.
It is.
So this isn't just about acing an exam.
Right.
It's about potentially saving lives. And trust me, understanding MI is fundamental for any doctor,
Absolutely.
no matter what specialty you end up in.
Mm-hmm.
So
Yep.
let's kick off with the basics.
Okay.
What exactly is a myocardial infarction?
Yeah.
We all know it as a heart attack,
Mm-hmm.
but let's get that clinical definition down pat.
At its core, an MI is the death of heart muscle tissue due to a lack of blood supply.
Okay.
Imagine a power outage in a part of your heart. That's essentially what's happening.
Wow.
Now, the usual suspect behind this blockage is coronary heart disease,
Right.
where those all-important coronary arteries get clogged up with fatty deposits called plaques.
Like a buildup of gunk in your pipes.
Yeah.
But in this case,
Mm-hmm.
it's your heart's pipelines getting clogged.
Exactly.
Definitely not a good situation.
Exactly. And these plaques can rupture,
Oh, wow.
triggering a blood clot that completely shuts down blood flow in the artery.
Oh, geez.
It's a medical emergency, and understanding why is crucial for both the MSRA and your future as a doctor.
Okay, so coronary heart disease is the main culprit.
Right.
But I'm guessing there are other,
Yeah.
maybe less common ways these heart attacks can happen?
There are.
The MSRA loves to throw curveballs.
Oh, yeah.
So let's be prepared for those.
You're absolutely right.
Okay.
While coronary heart disease is the most frequent offender,
Right.
our sources highlight some other sneaky culprits you need to be aware of.
Okay.
Think coronary artery spasms,
Okay.
where the artery temporarily clamps down, restricting blood flow,
Oh, wow.
or embolisms,
Okay.
where a rogue blood clot travels from somewhere else in the body and lodges itself in a coronary artery.
Oh, jeez.
And believe it or not, even a tear in the coronary artery itself, known as a dissection,
A tear.
can lead to an MI.
Hold on.
Yeah,
A tear in the artery?
it's rare,
That sounds terrifying.
but it can happen, and it underscores why recognizing these different causes is vital for accurate diagnosis.
Absolutely. It's like detective work.
Yeah.
Figuring out what's really going on behind those symptoms.
Right.
Speaking of which, let's talk about differential diagnoses.
Right.
Those conditions that might mimic an MI, but require different management strategies.
Right.
I bet the MSRA loves to test us on those.
Oh, you bet they do. It's all about thinking critically and ruling out other possibilities.
Mhm.
So what are some of those tricky mimics we need to be aware of?
Yeah.
Well, there's stable angina,
Okay.
which is chest pain that typically comes on with exertion and eases with rest.
All right.
It's caused by narrowed arteries, but not a complete blockage like in an MI.
Okay, so that's one to watch out for. What else?
Then you've got pericarditis,
Pericarditis.
which is inflammation of the sacs surrounding the heart.
Okay.
This can also cause chest pain,
Mm-hmm.
but it often has a different character and might be worse with breathing.
Gotcha.
And of course, we can't forget about good old indigestion,
Yeah?
which, believe it or not, can sometimes mimic the discomfort of a heart attack.
Wow. So you're in the exam.
Yeah,
You see a patient with chest pain.
right.
How do you, as a sharp UK doctor,
Yeah.
start piecing together this puzzle?
The sources we've reviewed really emphasize a systematic approach.
Yep.
First, dig into the details of the pain.
Right.
Is it crushing, tight,
Yeah.
burning?
Right.
Where does it spread?
Right.
What makes it better or worse?
Gotcha.
Then consider the patient's medical history.
Right.
Do they have any risk factors like high blood pressure, high cholesterol,
Mhm.
diabetes, or a family history of heart disease?
And let's not forget smoking.
Absolutely.
The British Heart Foundation
Yeah.
really hammers that one home.
They estimate that over 2 million people in the UK are living with coronary heart disease, which is a stark reminder of why understanding MI is so crucial.
Wow.
Now back to our patient in the exam scenario.
Okay.
You've gathered their history,
Mm-hmm.
assessed their risk factors,
Yeah.
What's the next step?
Well, the NHS guidelines make it clear that while chest pain is the most common symptom,
Right.
it doesn't always present in a textbook way, right?
You're exactly right.
Okay.
Sometimes it can be surprisingly mild,
Right.
even mistaken for indigestion.
Wow.
And this is particularly important to remember when dealing with certain patient groups.
Okay.
Women, the elderly, people with diabetes, and some ethnic minorities.
Okay.
They might not present with those classic symptoms, making diagnosis even more challenging.
Right.
The MSRA might try to trip you up with a scenario like that, so be ready.
Sneaky examiners indeed.
Right.
So we've got our potential MI case.
Yeah.
What investigations are we ordering to get to the bottom of this?
The electrocardiogram, or ECG, is your go-to tool in this situation.
Right.
It gives you a real-time view of the heart's electrical activity, and we're looking for specific changes that suggest damage, like something called ST segment elevation.
But even a normal ECG doesn't mean we can completely rule out an MI, right?
Absolutely.
Our sources made that point very clear.
A normal ECG doesn't give you a free pass.
Right.
That's why we turn to blood tests, specifically looking for cardiac biomarkers like troponin. When heart muscle is damaged,
True.
troponin levels rise, acting like a smoke alarm for heart damage.
I remember reading that troponin is incredibly sensitive,
Precisely.
like a microscopic bloodhound sniffing out heart damage.
And depending on the case and what we're seeing,
Right.
we might also consider imaging studies like an echocardiogram, which allows us to visualize the heart's structure and function, or even a coronary angiography,
Right.
which gives us a detailed roadmap of those coronary arteries.
Okay, so let's say we've confirmed the diagnosis.
Okay.
It's an MI.
Yeah,
Now we're talking time is muscle.
it is.
What are those critical first steps in managing this patient, especially in the context of the UK's healthcare system?
The UK guidelines are very specific on this.
Okay.
First and foremost, call for help. This is a 999 situation.
Right.
Then while we're waiting for the cavalry to arrive,
Yeah.
we need to act fast.
Okay.
Aspirin, 300 milligrams, chewed and swallowed. Wow.
Helps to thin the blood and improve flow to the heart.
Okay.
GTN spray can be given for pain relief.
Right.
And oxygen therapy is crucial to ensure that struggling heart muscle gets as much oxygen as possible.
It sounds like every second counts.
It
A
does.
real race against time.
It absolutely is. And depending on the type of MI and the resources available,
Okay.
the patient will then be considered for either PCI or thrombolysis.
PCI.
Yeah,
That's where they use a tiny balloon to open up the blocked artery, right?
that's the one.
And sometimes they put in a stent to keep it open.
Think of it as a minimally invasive plumbing job for the heart.
Oh, wow.
Thrombolysis, on the other hand, involves injecting clot-busting medication to dissolve the blockage.
So PCI is the preferred option if it's available quickly.
Exactly. It generally offers better outcomes and fewer complications compared to thrombolysis.
All right.
Now we've stabilized our patient.
Right.
The immediate crisis is over.
Okay.
What happens next? What about the long game? That's a great question. Let's dive into that and all the things that can affect a patient's recovery after an MI.
Okay.
Right after a quick word from our sponsor.
Welcome back to the deep dive.
Right.
We're talking myocardial infarction,
Yeah.
a topic that's not just a staple of the MSRA exam,
Right.
but a cornerstone of medical practice here in the UK. Before the break, we left off talking about those life-saving interventions for an MI, PCI, and thrombolysis.
Yeah.
But what happens after that initial crisis? What does long-term recovery and management look like for someone who's had a heart attack?
That's where secondary prevention comes into play.
Okay.
And it's a crucial aspect of post-MI care,
Right.
both in terms of improving patient outcomes and in how the MSRA might test your knowledge.
Okay.
We're talking about a multi-pronged approach here.
Right.
First, we've got medications like beta blockers to keep that heart rate in check,
Right.
ACE inhibitors to help the heart pump more efficiently.
And statins.
Right.
To tackle those pesky cholesterol levels.
Sounds like a whole arsenal of medications to help protect the heart.
It is. And the evidence really supports their use in preventing future cardiovascular events.
But medication is only one piece of the puzzle.
Right.
Lifestyle changes are equally crucial.
Absolutely.
We're talking about empowering patients to quit smoking once and for all.
Yes.
Adopt a heart-healthy diet that's low in saturated fat and salt, and incorporate regular exercise into their routine.
Exactly.
So it's a real lifestyle overhaul,
It is.
but one that could make a world of difference in preventing another heart attack.
Absolutely. And here in the UK,
Right.
we're fortunate to have fantastic cardiac rehabilitation programs
Yeah.
that provide comprehensive support to patients after an MI.
Okay.
They offer education on heart health,
Mm-hmm.
guidance on exercise, and even psychological support to help patients adjust to life after a heart attack.
From what I've read,
Mm-hmm.
these programs seem incredibly valuable,
They are.
not just for physical recovery, but for mental well-being too.
They truly are. It's a holistic approach
Yeah.
that recognizes the impact an MI can have on all aspects of a patient's life.
Right.
Now, while we hope for the best in terms of recovery,
Yeah.
it's essential to be aware of the potential complications that can arise after an MI.
Complications.
Yeah.
That's definitely something the MSRA can throw our way.
Oh, yeah.
What are some things we need to be prepared for?
Well, one of the major concerns is heart failure.
Okay.
This can happen if the heart muscle has been significantly damaged
Mm-hmm.
and can no longer pump blood effectively.
Right.
Arrhythmias or irregular heartbeats are another potential complication.
Okay.
And they can range in severity from being relatively benign to life-threatening.
So close monitoring is key in those early days and weeks after an MI.
Absolutely. And then there's the risk of cardiogenic shock,
Cardiogenic shock.
which is a severe condition where the heart is so weakened that it can't pump enough blood to meet the body's needs. It's a rare but serious complication that requires aggressive medical intervention.
Okay, so we've got heart failure, arrhythmias, cardiogenic shock,
Yeah.
all serious stuff.
Mm-hmm.
What about the long-term prognosis for someone who's had an MI?
Yeah.
What factors influence how well they'll recover?
Prognosis after an MI depends on a number of factors.
Okay.
The extent of damage to the heart muscle is a key consideration. The
Right.
more extensive the damage,
Yeah.
the higher the risk of long-term complications.
Okay.
Age also plays a role,
Right.
as does the presence of other health conditions like diabetes or kidney disease.
So it's a complex interplay of factors that
Yeah.
contribute to the overall picture.
It really is. And of course, the patient's adherence to those secondary prevention measures we talked about.
Mm.
Medications, lifestyle changes, and cardiac rehabilitation can
Good.
significantly impact their long-term health.
It sounds like a team effort between the doctor and the patient to achieve the best possible outcome.
Exactly. Now, shifting gears a bit, I know the MSRA can be a daunting exam
Yeah.
with so much information to remember.
It is.
So let's talk about some mnemonics and memory aids
Okay.
that might come in handy when you're in the pressure cooker of the exam room.
Mnemonics are a lifesaver, especially when you've got a brain full of medical facts.
They are.
Do you have any favorites for MI?
One that stuck with me is MONA for the immediate management of an MI. It stands for morphine, oxygen, nitrates, and aspirin.
Catchy and easy to remember.
Yeah.
What about those pesky risk factors?
Mm.
There's so many to keep track of.
Well, there's a handy one for that, too.
SAD cholesterol.
Okay. I'm intrigued. Break that one down for us.
SAD stands for smoking, age, and diabetes, 3 of the major risk factors.
Right.
Cholesterol reminds you of the importance of managing cholesterol levels.
Right.
Both the bad LDL cholesterol and the good HDL cholesterol.
Brilliant. That one's definitely going into my MSRA survival kit.
Good.
What about investigations?
Mm-hmm.
Any mnemonics to help us navigate those? I like to think of EchoCab.
EchoCap. Got it. What does that stand for?
Echo refers to echocardiogram, one of the key imaging studies we use to assess the heart.
Right.
And CIB stands for coronary angiogram and blood tests.
Right.
The other essential investigations for suspected MI.
Okay, that's actually really helpful.
Good.
I can see how these mnemonics can make a big difference when you're under pressure.
Yeah.
Now,
Yep.
let's tackle those dreaded SBA questions.
Right.
They're known for being tricky,
Yeah.
but I know with your guidance we can crack them.
You're right. They can be challenging.
Yeah.
But with a systematic approach, you can definitely master them.
Right.
Let's walk through a real-life case scenario to see how we can apply everything we've discussed so far.
Bring it on.
All right?
Let's put our MI knowledge to the test.
All right, picture this.
Okay.
You're an FY2 doctor in a bustling UK ED.
Okay, setting the scene.
Yeah,
Sounds like a potential MI case already.
a 65-year-old man.
Okay.
Let's call him Mr. Smith. Arrives complaining of severe chest pain. That started about 30 minutes ago.
Okay, what else do we know about Mr. Smith?
He describes the pain as a crushing sensation in the center of his chest,
Okay.
and it's radiating to his left arm.
Right, those are some serious red flags.
Yeah.
His symptoms and risk factors are certainly pointing towards an MI.
Yeah.
What are our immediate actions in this situation?
Remember, time is muscle.
Right.
And in the UK, we have clear guidelines for managing suspected MI.
Okay.
First things first,
Yeah.
call for an ambulance.
Right.
This is a 999 situation.
Okay.
While we're waiting for the paramedics to arrive,
Mm-hmm.
we need to initiate treatment promptly.
Right.
Aspirin 300 milligrams chewed and swallowed will help to thin his blood.
Okay.
GTN spray can be administered for pain relief.
Right.
And oxygen therapy is essential to maximize oxygen delivery to his heart.
Sounds like we're taking all the right steps.
Yeah,
What about an ECG? Would we do that immediately as well?
absolutely. An ECG is crucial in this situation. It's a quick and easy way to assess the heart's electrical activity and look for signs of damage.
Right.
And as expected in Mr. Smith's case,
Mm-hmm.
the ECG shows ST segment elevation in the anterior leads,
Oh, okay.
confirming our suspicions of an anterior MI.
Okay, so the diagnosis is confirmed.
Right.
What's the next step in managing Mr. Smith?
Yeah.
What does the UK protocol dictate in this scenario?
In the UK, the gold standard for managing a STEMI,
Right.
which is the type of MI Mr. Smith has,
Right.
is primary percutaneous coronary intervention, or PCI.
PCI.
If PCI is available within 120 minutes of first medical contact,
Oh.
that's the ideal course of action.
Okay.
It involves threading a catheter through an artery in the groin or wrist up to the blocked coronary artery
Okay.
and using a balloon to open up the blockage.
So we'd be aiming to get Mr. Smith to a cath lab as quickly as possible.
Precisely. Now, what if for some reason PCI isn't readily available within that time frame?
That's a good question.
Yeah.
I'm guessing there's a backup plan in case PCI isn't an immediate option?
Yeah. You're right.
Sure.
If PCI isn't accessible quickly enough,
Right.
we'd turn to thrombolysis, also known as fibrinolytic therapy.
Okay.
This involves injecting a clot-busting medication to try and dissolve the blockage.
Okay.
However, it's important to note that thrombolysis carries a higher risk of bleeding complications compared to PCI.
Right.
So it's considered a second-line treatment.
So PCI is always the preferred option if it's feasible within the recommended time frame.
Exactly.
Okay.
Now, let's say Mr. Smith successfully undergoes PCI.
Right.
He's stable.
Mm-hmm.
The immediate danger has passed.
Okay.
What about his long-term prognosis and the potential for complications down the road?
That's an important consideration.
Yeah,
We need to be thinking about the long game here,
right.
not just the immediate crisis.
You're absolutely right.
Okay.
Prognosis after an MI can vary quite a bit,
Yeah.
depending on a number of factors.
Right.
The extent of heart muscle damage is a key determinant.
Right.
The more damage there is, the higher the risk of complications like heart failure further down the line.
That makes sense.
Yeah.
What other factors might influence Mr. Smith's long-term outlook?
Well, his age is a factor,
Right.
as is the presence of other health conditions like diabetes or kidney disease.
Okay.
We also need to consider whether he experienced any complications during the acute phase of the MI, such as arrhythmias or cardiogenic shock.
So it's a complex interplay of factors that ultimately determine his prognosis.
It is, and this is where our understanding of MI needs to go beyond just the basics.
Right.
We need to be able to synthesize information,
Yeah.
weigh different factors,
Right.
and make informed decisions about management and prognosis.
It sounds like the MSRA is really trying to test our ability to think like a doctor,
That's exactly right.
not just regurgitate facts.
It's about applying knowledge to real-world scenarios
Right.
and demonstrating that you can think critically
Yeah.
and make sound clinical judgments.
Okay.
Now, speaking of real-world scenario, let's put our knowledge to the test
Right.
with an example SBA question.
Bring on the challenge.
Okay.
I'm ready to tackle an SBA question and see how we can apply everything we've learned.
All right, here's the question.
Okay.
A 70-year-old woman presents to the emergency department with sudden onset central chest pain.
Yeah.
She describes it as a tight, crushing sensation that radiates to her jaw.
Right.
She's also diaphoretic and nauseous.
Okay.
An ECG is performed, which shows ST segment elevation in leads 2, 3, and AVF.
Okay, so we've got a classic presentation here.
Yeah.
Chest pain,
Right.
radiation to the jaw, sweating, nausea,
Yeah.
all those red flags pointing
Uh-huh.
towards a possible MI.
Right.
And then we've got that ECG showing ST segment elevation.
Yeah.
But what does ST segment elevation actually mean?
That's a great question, and it's something the MSRA might expect you to know. The ST segment on an ECG represents the period when the heart's ventricles are contracting and pushing blood out to the body.
Right.
When there's damage to the heart muscle, like in an MI,
Yeah.
the ST segment can become elevated, appearing higher than normal on the ECG tracing.
Gotcha.
Now, those specific leads mentioned in the question,
Mm-hmm.
leads 2, 3, and AVF, tell us that the damage is likely in the inferior part of the heart,
Right.
which is supplied by the right coronary artery.
Okay, that makes sense. So we're thinking inferior MI?
Yeah.
But let's look at the answer choices to see if our thinking aligns with the options.
All right, here are the answer choices.
Okay.
A, stable angina.
Okay.
B, aortic dissection.
Right.
C, pericarditis.
Okay.
D, inferior myocardial infarction.
Gotcha.
E, pulmonary embolism.
Some tricky options in there.
Sure.
Let's break them down one by one.
Right.
Stable angina usually presents as pain with exertion,
Right.
not this sudden onset crushing pain. So we can probably rule that out.
Yeah.
Aortic dissection often causes a tearing pain that radiates to the back,
Right.
which doesn't fit our patient's description.
Yeah.
Pericarditis can mimic MI,
Yeah.
but the pain is usually sharp and worse with breathing,
Yeah.
which isn't the case here.
Right.
Pulmonary embolism is more likely to cause shortness of breath and pleuritic chest pain, which again doesn't quite match our patient's presentation.
Excellent analysis.
Thanks.
You've systematically considered each option and highlighted why they don't quite fit the clinical picture.
So that leaves us with...
D, inferior myocardial infarction.
Exactly. The clinical presentation, the ECG findings, and the location of the ST segment elevation all point towards an inferior MI.
Spot on. You've demonstrated that you can analyze the information, apply your knowledge of MI, and arrive at the correct diagnosis, which is precisely what the MSRA is looking for.
This deep dive has been incredibly helpful. I feel like I have a much better grasp on MI now.
Good.
Not just for the MSRA, but for my future practice as a doctor here in the UK.
I'm glad to hear that. Remember, the key takeaway here is that understanding MI isn't just about memorizing facts.
Right.
It's about developing a deep understanding of the pathophysiology, the clinical presentation, and the UK-specific guidelines for diagnosis and management.
Okay.
And don't forget, those mnemonics, they can be real lifesavers in the exam.
Absolutely. Mono-ona, sad cholesterol, echo-cab, they're all tucked away in my memory bank now.
God.
But beyond the exam, what really struck me is the importance of a holistic approach to MI management.
Yeah.
We talked about medications, lifestyle changes, and the incredible support offered by cardiac rehabilitation programs here in the UK.
That's a crucial point. It highlights the fact that as doctors, we're not just treating a disease, we're caring for a person.
Yeah.
And that means addressing all aspects of their health and well-being.
Well said. Before we wrap up, any final thoughts for our listeners who are gearing up for the MSRA?
I'd say keep learning, keep practicing, and don't be afraid to delve deeper into the topics that intrigue you.
Okay.
The MSRA is just one step on your journey to becoming a skilled and compassionate doctor.
Right.
And remember, resources like PassTheMSRA.com are there to support you every step of the way.
That's great advice. And remember, even though the MSRA might feel like a mountain to climb, you've got this with hard work and dedication. You can conquer this exam and embark on a fulfilling career as a doctor here in the UK.
That's right. You've got the knowledge, the passion, and the drive.
Right.
Now go out there and make us proud.
That's a wrap on this deep dive into myocardial infarction. Until next time.
All right.
Keep those brains buzzing and those stethoscopes ready. We'll see you on the next episode of The Deep Dive.